Good evening, all. I am Dr. Ankit Bansal from Jaipur. Today, Chess Council of India come up with a very innovative webinar. We routinely face respiratory failure in our clinical practice, but there are certain respiratory failures which are unexplained. So today, we will be taking the insight of these respiratory failure. What are the various common causes related to it? How to diagnose them and how to manage. For this, with me today, we have our esteemed faculties with us. We have Dr. Atri Gangopadhyay from Ranchi. We have Dr. Nilanjan Umesh from Kochi. We have Dr. Nupur Kulkarni from Margao, Goa. We have Dr. Mansi Gupta from Lucknow. And we have our cardiologist friend, Dr. Arpit Jain from Indore. Today, we will start the spectrum with a case presentation, first by Dr. Atri, followed by Dr. Nupur. So I hand over my mic to Dr. Atri.
Thank you, Dr. Ankit, for the kind introduction. Thank you, Chess Council of India, for giving me opportunity in this webinar. Thank you, Alkem, who are the academic partner of this webinar. I am Dr. Atri Gangopadhyay. I am based at Ranchi, Jharkhand. And I am going to present a case where shortness of breath was due to shortness of neurotransmitters. A 50 years lady who is a school teacher, she was hypertensive last 5 years on amlodipine 5 mg, no family history of asthma. She was admitted with acute type 2 respiratory failure. In the emergency, her ABG showed pH 7.29, PCO2 85, PO2 65, SPO2 89% at room air, bicarbonate 26. We immediately started her on NIV. We made a working diagnosis of acute severe asthma as she had a silent chest, no wheezing. She was started on SABA ICS nebulization, broad spectrum antibiotics. After 2 hours, her ABG started showing improvement. pH improved to 7.33. PCO2 came down to 62. Bicarbonate normal range. PO2 increased to 78 and NIV at 50% FiO2 showed a SPO2 of 95%. When we removed NIV the next day morning, after 30 minutes, patient suddenly became apneic unresponsive. We gave her AMBU bag and mask ventilation and she was revived. She did not need any ionotropic support. So we suspected a cardiac issue. So we did a cardiac consult, Holter was put, echo was done, coagulation profile, all came out to be none. As patient was on NIV support, we were unable to do a CT scan. We did a bedside chest X-ray. The bedside chest X-ray was unremarkable. Next day, when the nurse was doing mouth care of patient, again the patient became unresponsive or apneic. Again, immediate AMBU was done, patient revived. Now, on that BiPAP support, we did a CT thorax plane. We could not give contrast due to unstable patient. And this CT thorax plane revealed normal lung finding, but they told about an anterior mediastinal mass. The anterior mediastinal mass was so small that it was not visible on the chest X-ray. The cardiac or mediastinal silhouette on the chest X-ray was normal. It was visible on CT. When we saw this anterior mediastinal mass, we sent certain blood tests which confirmed that this was a myasthenic crisis. So our patient was suffering from a thymoma and myasthenic crisis. Patient was started on physiostigmine, leading to successful weaning from the NIV in the next 24 hours. Now the patient is discharged. She is only taking BiPAP overnight. She is on oral physiostigmine and they have planned a thoracic surgery. I would now pass on to my next speaker, Dr. Nupur Madam, and then we shall go on to the discussion on unexplained respiratory failure. Over to you, Dr. Nupur.
Good evening, everyone. At the outset, I would like to thank the entire team of CCI for making me a part of this wonderful webinar. And thank you, Dr. Atri. The case presentation was wonderful, and we got to understand myasthenic crisis in detail. So let's move on to the next case, which is a perplexing cause of respiratory failure. So there was a 38-year-old married and nulliparous female who presented to the ICU with complaints of dyspnea, dry cough, oliguria over the last 3 days, so which was quite a rapid progression. And she had no history of fever, rash, or any abdominal or urinary complaints. However, her past history was significant for recurrent arthritis, a malar rash, and a history of CVA 8 years ago. She had no other comorbidities, and she was a non-smoker. So when she came to us, she had a pulse rate of 128. So she had tachycardia, BP was normal. She was breathless, and saturation at room air was 82%. Her RBSL was normal. She was slightly drowsy. ECG showed sinus tachycardia, and room air ABG revealed type 2 respiratory failure. And on examination, her skin showed changes of livedo reticularis as well. On initial evaluation, she was found to have anemia, thrombocytopenia, a slightly raised creatinine with mild transaminitis, procalcitonin levels of 1. Quantitative D-dimers were done because patient came with a rapid progression and hypoxia. D-dimers were normal. And the initial infective etiology workup was normal. It was negative. Screening echo showed a grade 2 MR and certain vegetations on the mitral valve. So this was her X-ray at presentation, and you can see that there are bilateral patchy, fluffy opacities. And on the right, you can see an image of the echo, which shows the vegetations on the mitral valve. So she was started on antivirals, broad spectrum antibiotics, and other supportive management. And in view of the type 2 respiratory failure, she was given a trial of NIV. However, the patient worsened and she developed shock. She had to be intubated and was an invasive mechanical ventilation, and therefore started on vasopressors and steroids as well in view of the rapidly progressive disease. Eventually, she developed acute renal failure and had to be started on renal replacement therapy. And in view of the rapid progression, she was considered for BAL, and bronchoalveolar lavage was showing hemosiderin-laden macrophages. BAL was also sent for culture to rule out other infective etiologies, but cultures, however, were unyielding. So as you can see the X-ray after she worsened, there is a significant increase in the pulmonary opacities, and a CT scan which is obtained shows us bilateral extensive GGOs. So here, in view of the background of anemia, thrombocytopenia, a rapidly progressive disease, along with bilateral GGOs, and considering that the female is married and nulliparous and also has history of CVA, we considered evaluating for any underlying connective tissue disease. And very well, CTD profile did show a positive lupus anticoagulant and anti-cardiolipin antibodies, as well as positive for anti-beta-2 glycoprotein 1 antibodies. And to rule out other causes of pulmonary hemorrhage, ANA, anti-dsDNA, ANCA, anti-GBM were done, which were negative, and complement levels were normal. And that's why we could come to a conclusion of a catastrophic antiphospholipid antibody syndrome, which is CAPS. And her peripheral smear, which was done, also showed presence of schistocytes. So after this, she was started on cyclophosphamide as well as plasmapheresis. And within 48 hours, the patient showed very good improvement. She could be extubated. Her X-ray eventually cleared. And as you can see on the image, the CT scan also shows marked clearing of her ground glass opacities. So what exactly is CAPS? It's basically a rare and life-threatening form of antiphospholipid antibody syndrome. And it basically entails severe thrombotic complications, which may be either microvascular or involve large vessels. And by rule, it affects multiple organs. The organ involvement develops simultaneously, and it is rapidly progressive. And approximately 1% of patients with antiphospholipid antibody syndrome develop CAPS. And this disease is more common in females. Not as a rule, but however, more commonly it is seen that these patients usually have a triple antiphospholipid antibody positivity with high titers of anticardiolipin and beta 2 GP1 antibodies. The exact mechanism of this disease is not known. It may be due to immune mediation or variation in coagulation factors, activation of complement, or sometimes even the two hit mechanism, whereas the first hit is either a gene abnormality or presence of antiphospholipid antibodies, and the secondary factor, that is the second hit, is an underlying enticing event like an infection or a injury or pregnancy. Other risk factors include withdrawal of anticoagulants or active SLE. So as we know, there are multiple organ systems involved with antiphospholipid antibody syndrome, and it is similar with CAPS. So in CAPS, the most common organ to be involved is the kidneys, and lungs are the next most common. Almost 55% of them have lung involvement. Now, as per the CAPS registry, which studied more than 500 patients of CAPS, what we saw is that when it comes to pulmonary involvement, the most common manifestation was pulmonary thromboembolism. The second is diffuse alveolar hemorrhage with or without pulmonary embolism, and hypocomplementemia may be associated with DAH. In patients who do not have pulmonary embolism, they may have underlying pulmonary capillaritis. So, as per the latest guidelines, what we follow is the Ashish criteria for diagnosis of CAPS, which includes involvement of 3 or more organ systems within a duration of 1 week, confirmed either by histopathology or presence of antiphospholipid antibodies. So, most importantly, IVIG and plasmapheresis are usually recommended as first-line therapy, and this happens only in CAPS. So, normally in antiphospholipid antibody syndrome, these are not the first line of management. So, usually a triple therapy, which includes presence or combination of glucocorticoids, anticoagulants, that is heparin, and plasmapheresis or IVIG. This is usually what is recommended as first line. Standalone glucocorticoids are usually not recommended in these patients unless and until patient has an active underlying SLE. And in refractory cases, we may also use rituximab and esulizumab. Thank you.
Thank you, Dr. Atri and Dr. Nupur. They were the excellent cases, and possibly we had a very nice start to our webinar. So, what traditionally we have been learning about respiratory failure, maybe there could be 2 types of respiratory failure: hypercapnic respiratory failure. Possibly we could have been learning that arterial PaCO2 more than 45, or hypoxemic respiratory failure with which the PO2 less than 60. So these are the definitions which we traditionally used to hear. Yes, the presentation can be acute, it can be chronic, and sometimes it happens that both the phenomena coexist. Hypoxia followed by hypercapnia, hypercapnia followed by hypoxia. In our understanding, possibly respiratory failure can arise, particularly any kind of failure related to your effector mechanism of respiratory system. And that effector mechanism include what? It include your central nervous system, your peripheral nervous system, respiratory muscles, and the chest wall airways or alveoli. So any of these defect may possibly cause your respiratory failure. So including our esteemed faculties now, with this extensive webinar, I first come to Dr. Atri, to the case which he presented. So Dr. Atri, your lady was 50-year-old with shortness of breath, initial working diagnosis of acute severe asthma, and between spells she had apneic episodes. And we defined this as myasthenia crisis. So in this effector mechanism, where we place myasthenia, first thing, how these are diagnosed as a cause of unexplained respiratory failure. And your diagnosis, your slide suggests that there was an involvement of possibly anterior mediastinal mass. So how we correlate these mediastinal masses with myasthenia, how they are managed, and are there any surgical options for that?
When we see the physiology of respiratory failure, somewhere there is a neuromuscular cascade. Myasthenia comes in that effector mechanism or neuromuscular cascade, that basically the signal for taking breath or signal for leaving breath is not coming properly. Somewhere there is this muscle weakness which is also contributing in faulty respiration. I would want to give a personal note over here. Rare disorders are not so rare if you look at it properly. When I got a call that a 50-year lady has come in respiratory failure, short history. So the first thing came to my mind is this must be acute severe asthma with silent chest. Maybe she has fatigue. When I auscultated the lady, I did not get any added sounds. So the first thing in my mind came that due to that ventilatory failure, the person is having a silent chest. And because of that rise PCO2, we immediately put her on NIV to prevent an intubation. And as per protocol of asthma, we started nebulized SABA ICS. But what I understand now is the person responded to the NIV rather than to that SABA ICS. So when after 2 hours of NIV, we found that the ABG is improving. So what we opined was the status asthmaticus is improving. So when we started to weaning her, when there was that apnea, first thing we thought that maybe this is a cardiac event, that the patient become unresponsive because cardiac emergencies are any day much more common than myasthenic crisis. So we requested a cardiologist. That person did a Holter and everything, and that also came normal. That is when the next day I had come in the round, and before me only the sister was doing the mouth care, and I saw her going apneic. And then it struck my mind that this can be something from that effector mechanism or neuromuscular path. If you ask me what diagnostics we did, there are certain blood tests. Myasthenia is supposed to be an autoimmune disease. So there are certain blood tests, anticholine receptor antibody, then antibody against striated muscle kinase, antibody against muscle specific kinase. Out of these three can diagnose you more than 98% of the patient. The most powerful test is that anticholine receptor antibody, but there is a certain subset of myasthenia known as seronegative myasthenia, where this test is negative. So if you order that anti-MuSK antibody or muscle-specific kinase, that comes positive in those patients. So this is how you can diagnose the test. We found an anterior mediastinal mass, but that is not mandatory for diagnosing someone as myasthenia. Myasthenia is more of a functional abnormality than a structural abnormality. In very few patients, that thymus may be increased to give us this anterior mediastinal mass. But another retrospective evidence for this thymoma is that many patients of myasthenia, if you do surgery thymectomy, even if there is no enlarged thymus, that also helps the patient over a period of time. But one importance of this thymoma is that thymoma is a cause of reversible myasthenia. That if you immediately inform your cardiovascular or thoracic surgeon friend that after you manage the muscle weakness by giving this autoimmune medicine, by giving physiostigmine, pyridostigmine and its analog, and then if you plan the surgery, after surgery, patient may require complete removal of these medicines over a period of time also. Just like I always tell my fellow colleagues that there is a reversible cause of CKD like multiple myeloma. Similarly, reversible cause of myasthenia would be this thymoma. Over to you, please.
So a very good insight is given by Dr. Atri that when you are suspecting respiratory failure, it is not only asthma, COPD, or the traditional diseases which we are used to treat. So there has to be a suspicion that some of the effector mechanism can be involved. Myasthenia is one of those. So a prompt diagnosis is important. And yes, treatment options are available. It can be treated. And if there are certain neoplasm, once patient optimized, can always give option of surgical intervention. Now I come to Dr. Nupur. Your case also was a very unusual case. In the first instance, we did not come to the suspicion of this particular syndrome. So you are a 42-year female with dry cough, oliguria, progressive dyspnea, eventually diagnosed as antiphospholipid antibody syndrome. So what was the point at your clinical evaluation? It comes to notice that you have to think out of box. Possibly you have to diagnose this entity and you have to send the investigation for the diagnosis. So my question would be, what was the suspicion at that point? Diagnosis, already you gave the slides. What are the treatment options that are with us to treat the patient? Dr. Nupur. You are mute. You have to unmute.
Yeah. Thank you, sir, for the question. So, usually in our routine practice, we don't really see these cases, these kind of patients so commonly. So, someone coming to us with respiratory failure, we usually tend to think of infective causes first. But this patient, she was young, she was married, but nulliparous. And the thing is, we have to also look at the past history in these patients. Now, when a patient comes with respiratory failure, we may not have the time to actually sit and go through the respiratory, the past history. So, the first thing we need to do is stabilize the patient. What we need to also understand is that this patient had a significant past history in terms of a malar rash. On examination, she had livedo reticularis. She had a history of a CVA in the past without any underlying comorbidities like dyslipidemia. She was not diabetic, non-hypertensive as well. And we also need to see one is whether there is any multi-organ involvement as well. So that should make us think of a systemic cause. At the same time, we also have to look at the patient in terms of how rapidly the patient is deteriorating. So this patient came with a very short history of 3 days, and she rapidly progressed from NIV, and she ultimately had to be intubated. And at the time of presentation itself, she had a multi-system involvement. So in females, we need to think of underlying connective tissue disorders also. At the same time, pulmonary hemorrhage. So when you have an X-ray or a CT, which shows you multiple GGOs, dense consolidations, and your patient has anemia or serially dropping hemoglobin, and at the same time there are new infiltrates or worsening infiltrates on your X-ray, you must think of alveolar hemorrhage also. So alveolar hemorrhage, usually patients present with hemopsis. That is one of the triad of symptoms, but almost 1/3 to 40% of patients don't present with hemopsis. So in this patient, that's how we thought of probably an underlying alveolar hemorrhage, because she came with anemia, dropping hemoglobin, and that's what prompted us to do a bronchoalveolar lavage, and that showed a hemosiderin-laden macrophages, and that's what claims the diagnosis. So in these patients, usually you have to rule out other causes of alveolar hemorrhage as well. So doing anti-GBM antibodies, ANCA, is also very important. And usually someone with antiphospholipid syndromes, we need to also consider any underlying active lupus. So that should usually tell us to add steroids. So usually at the outset, usually in the first therapy that the patient is given is steroids with anticoagulation with IVIG or plasmapheresis. You may add other immunosuppressants. And if the disease is refractory, then you have to consider other therapies such as rituximab or esulizumab.
Oh, that's an important thing, as said by Dr. Nupur, that the physical examination, the clinical history is very important in these particular set of patients. And if they are having any past history, like the past history of CVA in this particular group of patients, that is very important, because if you have to correlate it with the current scenario, these things are very important. And particularly if females are there, you have pulmonary hemorrhage, definitely you need to do a CTD workup, you have to root vasculitis, and particularly the rare phenomena like antiphospholipid antibody syndrome. Thank you, Dr. Nupur. So coming over to the effector mechanism, as we have discussed, that the effector mechanism start with the CNS efferents, followed by peripheral nerves, then respiratory muscles and chest wall, then airways and alveoli. So the most important part is now comes to CNS. So I open my discussion with Dr. Mansi Gupta that we know that central nervous system is an important aspect of this unexplained respiratory failure. So what are the various causes contributed to it? I would like you to focus particularly on the structural disease of CNS, which can contribute to it.
So, when we're talking of respiratory failure, we must understand there's a basic respiratory physiology which starts with CNS being the center of, starting and initiating a breath. And then through the, nerves, it comes down to the muscles, the respiratory muscles, and that's how we are going to have ventilation in the alveoli. So that's the basic pathway that we are following. So brain actually initiates the breath or triggers a breath. So any particular, and the two most important regions of brain which are specifically involved in breathing control is medulla and pons. So any pathology which will affect the structure of medulla and pons in terms of any things which I'm going to enumerate can actually interfere with the normal breathing pattern. So when we talk of what structural things can happen, we always talk of 5-6 things. It can be a trauma which can lead to a hemorrhage, or it can be a vascular cause which can be in the form of a hemorrhage, or it can be a vasculitis, and there are infections. There could be a structural abscess sitting over there, infective abscess. There could be encephalitis with secondary involvement into the brain. So those are the structural causes. And other things which can happen are also, as I've mentioned, that injury to the brain in any form. Then there are many other causes which are non-structural causes which may also affect the breathing, which I'm sure
we'll discuss with that.
Yeah, we'll discuss with that. Yes.
So there are a very good number of causes which can directly involve the various parts of CNS, and they can contribute to this unexplained respiratory failure. Now, as Dr. Mansi has rightly said, that there are some other causes other than the structural causes which can contribute to it. So I come to Dr. Nilanjan. What are those other causes other than the structural? And I think that maybe drug related overdosing may also affect the effector mechanism. So what are the various drugs which can contribute to it? What are the treatment options available with us? Dr. Nilanjan.
Good evening, everybody. Thank you, Dr. Ankit, for the question. So Dr. Mansi has already explained about the structural causes of CNS. So coming to the drugs which can cause unexplained respiratory failure, the main ones are first of all opioids. Opioids are commonly given by our anesthesia colleagues, and in the Western world, opioid use is quite common. Off the counter, you can still get opioids. In our country, it's a little difficult to get opioids, morphine, fentanyl, etc. over the counter. There are strict laws against it. But still, any patient who is coming with drowsiness and having unexplained respiratory one opioids. The other one is benzodiazepines. Benzodiazepines are also very commonly used nowadays, available over the counter, and these ones can also cause unexplained respiratory failure. For opioids, the antidote is naloxone. Naloxone, we give 0.5 mg of naloxone, and this naloxone, it instantly reverses the respiratory failure produced by opioids. The patient will instantly start breathing at his normal rate, and he will even wake up. For benzodiazepines, it is flumazenil. Flumazenil, the dose is around 0.3 to 0.5 milligram. And again, it also has an instantaneous effect. The patient can suddenly wakes up. Recently, we had a patient 2 weeks back where instantaneously on giving flumazenil for an overdose of alprax, the patient up and started breathing normal. And one important cause of unexplained respiratory failure I would like to describe is that of snake bite. Snake bite is quite common in our country, and any patient who comes with unexplained respiratory failure, we don't know what happened. Patient was found unconscious and desaturation. Snake bite is an important cause, and ASP again and snake venom use instantaneous results. Other drugs like alcohol, alcohol, it can cause some amount of sedation and some amount of bradypnea. There's no as such. We just need to wait and watch and probably give respiratory support till the patient wakes up and the effects of the alcohol itself. So I think drugs.
Any metabolic causes contributing to it?
Yeah, the metabolic causes. See, if any patient who goes into has repeated vomiting or so over-diuresed and goes into metabolic alkalosis. So these patients will try to compensate by increasing their carbon dioxide levels to compensate for the increased bicarb. So they start going into hypopnea, bradypnea, and these can overcompensate, and sometimes this can lead to type 2 respiratory failure and yeah.
Okay. You have briefly summarized about the various drugs and possibly the antidotes we are having and the various metabolic causes. Dr. Mansi, this is a very big, what we call the CNS abnormalities. They are very big structural diseases, metabolic, and maybe drug overdose. I know if we are coming with conventional respiratory failure, then we are looking up the cause. How we evaluate the investigations of choice, particularly to look for these causes, to rule out as CNS as a cause of unexplained respiratory failure.
So what we are following this whenever you're having a patient who's having respiratory failure and you have done an ABG, but most important thing we have to realize in CNS being cause of respiratory failure that your patients are basically hypoventilating. So it's a good practice to know that their CO2 levels are high and they may be having a low oxygen, but their air gradient doesn't change. So that thing you have to, when you're doing an ABG arterial blood gas analysis, and they're easily oxygenable, these patients. So that gives you a clue that this patient is hypoventilating for some reason, but there is no true hypoxia in terms of pulmonary alveolar involvement, in terms of a VQ mismatch or a shunt problem. So there you actually suspect one thing. Then there are pointers in a patient's body habitus or a physique. Suppose we are suspecting an obese patient, that we can actually suspect him to have an obesity hypoventilation problem, which is again centrally controlled because of the loss of chemoreceptor sensitivity in the long run. But the basic thing, when you suspect a CNS being cause of respiratory failure, you have to dig into the history of the patient. You have to really delve into what patient drugs he was using, what kind of a lifestyle he has. So history plays a very big role in evaluating such patients. Also, if your patient is a patient, the history of trauma and other things will come very forthcoming. But drug abuse and everything, you have to really sit down with the family sometimes, and then that's how you, and certain times you still miss on history, and eventually while following up the patient, when you're managing during that course, you are able to get hold of that kind of history, that he was a drug abuser or something like that. The other clue comes from the patient's breathing pattern also. So if you're keen enough to understand the different types of, all of us actually are not very, we have busy schedules, but then there are various types of abnormal breathing patterns, which are very typical of central cause of respiratory failure. And we are very, it's common for us to see chain stroke respiration in patients of heart failure. We have seen it multiple times in our patients where central apneas are happening with a classical crescendo decrescendo pattern that can be made out. We're also aware of the Kussmaul's breathing, which happens in the acidotic patients. So again, there is apneustic type of breathing where you have prolonged inspiration with very patchy kind of expiratory pattern. Then there is a very this ataxic breathing. So all these pointers are there in the breathing pattern. We should just stand by the patient for some time and look how and see. That's what I think happened in Dr. Atri's case also, that he could pick up from the pattern of the patient's breathing that, something more than asthma, because they have asthmatics have a different breathing pattern. Having said so, ABG also gives a clue. So like we were discussing the metabolic causes. So in metabolic causes, sometimes ABG plays a big role. Like in, if you're getting a patient of, poisoning or something like that. So those things can be picked up in the ABG if you're very good at, reading your ABGs, the alkalosis that he was talking about. So those things can be picked up, especially if a patient, if you're, when you're evaluating a patient, you should be, the whole idea is whenever respiratory failure cannot be fully explained by the respiratory conditions, like in first case we have seen asthma was suspected, but, classical findings of asthma are not there. Then you should obviously move beyond extrapulmonary in all the
Yes,
cases,
I totally
and
agree.
complex kind of a situation where you can have multiple factors coming into play, not just CNS but other extrapulmonary factors also, which I'm sure we are going to discuss. So that is how. And obviously when you suspect something in terms of imaging, it's better to involve a neurologist colleague also, so
Yes.
that he can guide you better in terms of what investigation should be the first thing to do in such cases.
Yes, definitely agree. So we need a comprehensive workup in that particular, and again, history and the clinical presentation and the bedside test matters a lot. So, Dr. Nupur, there is an important link between the CNS and your respiratory muscles, and these are your peripheral nerves. So, what are those possible causes that are affecting the peripheral nerves?
So, Dr. Nilanjan and Dr. Mansi have elaborated about the central causes, let's move on to the peripheral nervous system now. So, the peripheral nervous system also is a part of the effector mechanism in terms of your respiration. And again, one very important cause in patients who come with unexplained respiratory failure. So, here also history is important because there are many patients who have either they will have peripheral neuropathy, or they will have motor neuron disease, or they may have myopathy. So they will have a prior history before coming with respiratory failure. So what I mean to say is that these are usually chronic progressive conditions, and respiratory failure usually happens quite late in the disease trajectory. So if you look at the patient's history, the patient may already be having some sort of a muscle weakness. If the patient has say a motor neuron disease, okay, so patient may have say amyotrophic lateral sclerosis, etc. Patient usually will have muscle weakness. On examination you may find muscle atrophy, there may be fasciculations, you may find spasticity also in these muscles, and very often in these patients they have a bulbar component also. And usually this kind of a bulbar component will predispose the patient to having dysphagia or dysarthria. They will have difficulty in clearing of secretion. So pooling of secretion is very common in these patients, and this also causes recurrent aspiration, pneumonia, and can also contribute to development of respiratory failure in these patients. Of course, they also have respiratory muscle weakness, due to which they are not able to take deep breaths. At the same time, they may have a poor cough reflex also. And this also contributes to pooling of secretions in these patients. Then you have diseases which involve the peripheral nerves. So you have very classically the Guillain-Barré syndrome.
Mhm.
So very often these patients also present to you with respiratory failure, and these patients eventually do end up on invasive mechanical ventilation as well. Then you have diseases which involve the neuromuscular junction. Classically, like Dr. Atri described, a patient of myasthenia gravis who comes with myasthenic crisis. So, roughly around 10 to 15% of patients who have myasthenia gravis can come to you with in crisis itself. So patient usually develops hypoventilation, and if you ask the patient or the family the history, they will give you non-specific complaints like generalized weakness. You might find ptosis. The patient usually has an inciting factor. So patient may have had an infection, a recent surgery, or certain drugs like usage of neuromuscular blockers or antibiotics like your aminoglycosides, which also cause neuromuscular blockage. These are the ones which will precipitate crisis in these patients. Apart from that, you may have botulism or patient with Lambert-Eaton myasthenic syndrome as well. So these are the usually these are the causes. So in these patients, a chronic history before the patient presents with respiratory failure is important. Looking for symptoms of other muscle weakness is also important in these patients. Another thing important to remember in these patients is that a lot of patients with CNS disease or myopathies also, they are going to eventually develop some amount of sleep related breathing disorder or sleep linked hypoventilation. So that is also something which we need to look out for, because a lot of these patients also present with respiratory failure.
Yes, definitely, Dr. Nupur. There is an elaborative list with these patients who have these type of disorders. Moving to the next, the muscle is also a very important part of effector mechanism. Dr. Nilanjan, what are the various myopathies with us, and what are the diagnostic and management options for those set of patients?
So, myopathies is a big umbrella of diseases. It can be congenital or it can be acquired. Like we have congenital and genetic myopathies or other muscular dystrophies, which can gradually progress into respiratory failure. And the myopathies that we have, the mainly the inflammatory myopathies, which again have a chronic course, and finally respiratory failure is one of the late presentations. Inflammatory myopathies, mostly polymyositis, dermatomyositis, or the mitochondrial myopathies. So, treatment options in these cases, when they come in an acute situation as respiratory failure or with a classical symptoms, then the treatment for the as a rescue is steroids, and we can even in consideration with our neurology or neurology colleagues, many of them are given IVIG as a rescue measure. Now, for diagnosis, there is a host of antibodies for each of these myositis, like for dermatomyositis and polymyositis, the anti-Jo antibodies, which come positive. In our hospital, there is a myositis panel, which is a big list of antibodies, and any of them come positive. We can classify accordingly as one of the myositis. And another distinct investigation is the creatinine phosphokinase. The CPK will be elevated in these patients. So, yeah, that helps us in the value of the higher the CPK, it shows that more the inflammation. And finally, if you are confused as which category of myopathy or which category of myositis, muscle biopsy is the option that we have here in the muscle biopsy. So, treatment options I've already told, it's mainly steroids. We have some of them, we can give immunosuppressants like azathioprine and IVIG in case they come in a very refractory condition with refractory respiratory failure with requiring intubation, severe neuromuscular weakness. And definitely we need to consult with our neurology or our neurologist also before going for those steps.
So, Dr. Nilanjan, diaphragm is an important muscle.
Yeah.
And sometimes we encounter diaphragmatic palsy or diaphragmatic paralysis. So, in a routine practice, how to diagnose it? And are there any management options available with us for diaphragmatic palsy or paralysis?
Yeah, diaphragmatic palsy or can also, the patients can have a normal X-ray and a CT. Can be the diaphragmatic weakness alone, which is causing the respiratory failure. So, the if you for diagnosing initially we can do an ultrasound. Most of us now we do an ultrasound, or the emergency physicians they start their examination the routine ultrasound. The ultrasound will show the loss of the diaphragmatic contour. There will be decreased diaphragmatic excursions along with respiration, along with inspiration and expiration. And we can also quantify the thickness of the diaphragm. So, patients who are having a chronic respiratory condition leading to diaphragmatic weakness, they will be having a low diaphragmatic. The thickness of the diaphragm will be less. Okay. And if we ultrasound, if we are not able to come to a conclusion with ultrasound, we have fluoroscopic studies. They are a much better option. We may not be able to do it in an emergency situation, but fluoroscopic studies are there, which can again quantify the movements of the diaphragm. And the gold standard for diaphragmatic weakness is phrenic nerve stimulation. So that's again needs the help of a neurologist. We stimulate the phrenic nerve and see for the diaphragmatic movements. And if the phrenic nerve is involved, if we are having any condition that involves the phrenic nerve, like malignancy or some infections which are affecting the phrenic nerve, again, this can cause diaphragmatic. Treatment options are for diaphragmatic weakness per se is limited. Diaphragmatic weakness and diaphragmatic dysfunction should be are different conditions. Diaphragmatic dysfunction means like any patient on the ventilator who are on ventilator for a long time, they will be having some amount of diaphragmatic dysfunction, which is due to disuse of the diaphragm. So, the patients of those patients, we just need to give adequate time. We need to if they are on the ventilator, we need to give them positive pressure, adequate pressure support trials, and gradually the diaphragmatic system will improve. The diaphragmatic dysfunction will reduce, and the only problem will be we will have difficulty in breathing, but ultimately we will be able to get them out of a ventilator. And if it is permanent paralysis or severe paralysis, then there are very few options actually. One is persistent phrenic nerve stimulation. The other one is the certain surgical measures like diaphragmatic plication. And very few, like in Western countries, there is something called a diaphragmatic pacemaker. We can pace the diaphragm just like our heart and get adequate contractions, which can help in our resolving our respiratory failure. So, not many options. If you are having a permanent diaphragmatic, uh, yeah.
So I
I want
would
to
like
put
to
in a very quick point.
Yes.
Whenever we are talking about unexplained respiratory failure, just like magicians are supposed to have that magic wand, corticosteroid becomes that magic wand of pulmonologist and intensivist. A little bit of corticosteroid in that critical situation will not harm anyone. Autoimmune corticosteroid, edema related problem, some corticosteroid, weakness related problem, some
Yes.
corticosteroid. So it will definitely help the patient by the time you're getting, let's say, buying the time for diagnosis. This is one point I
Yes.
would push into every audience. Please continue.
Very true. Yeah,
I would
completely
like
agree.
to congratulate. Yes, please. I would like to congratulate you all because we have 1049 logins for this unique topic that we are discussing. I would like to congratulate all the panelists and congratulations Team CCI and Team Alkem for organizing such a unique concept. Please go ahead, Dr. Nupur. Dr. Nilanjan, you want to say anything regarding more
No,
diaphragmatic? Okay,
no, I
done.
just wanted to completely agree with Dr. Atri. Steroids resolve things most of the time. It's time to
Yes, it has a
for our
detrimental effects
diagnosis.
also in the long run. Uh,
Yeah, that's
so,
also there. But
yes,
as a rescue measure, probably for a short duration.
yes, definitely, definitely. Dr. Nupur, frequently we find the situation in which our neurologist colleague uh, are diagnosing and following a case with motor neuron disease. They will call you for help. Possibly they think that the patient would be a type of palliative care for their sort of patient. They need a PAP therapy or something like that. So, what are the points at which you decide that your patient may require that PAP therapy?
Thank you, sir. So, when a patient of motor neuron disease, or for that matter, these kind of progressive neurological disease is referred to us, we first of all we need to counsel the patient as well as the family that this is going, they are in it for the long run, and this disease is going to progress, and eventually the patient is going to develop respiratory failure. So they should be mentally prepared to use non-invasive ventilation or a PAP therapy at home. So, first of all, when these kind of patients are referred to us, what we need to understand is a basic investigative modality, that is spirometry. So, a PFT is very important in these patients. And as per the latest guidelines, which were released last year, every 6 monthly is usually what is recommended. So, every 6 monthly, we do a PFT in these patients. We need to look at the FVC of the patient. And there are certain spirometric criteria as per which we can decide to start the patient on NIV. So if the patient's FVC is less than 80% of predicted and the patient is symptomatic, or if the patient's FVC is less than 50% predicted, whether the patient has symptoms or not. And there are certain other parameters which are also disturbed. For example, the peak cough flow is less than 270 liters per minute for adults. The maximal inspiratory pressure is reduced. The maximal expiratory pressures are reduced, and the patient's sniff, that is the sniff nasal inspiratory pressure, also is reduced to less than 70 in males or less than 16 females. So these are certain objective criteria which entail the patient to use an NIV at home. However, if you find that the patient is not satisfying any spirometric criteria, what you need to do next is ABG as well as an overnight oximetry. So, like I said, many of these patients do have sleep-linked hypoventilation or a breathing disorder. So that is what we need to also understand. So if these patients do have any of these criteria, so if the patient is hypoxic or having hypercapnia, that is another indication where the patient needs to be started on NIV. And if none of these are present, the patient must undergo a level 1 polysomnography. And we need to document hypoventilation also in these patients. So you may use a transcutaneous CO2 or an EtCO2 in these patients. And if there is evidence of sleep-linked hypoventilation or a sleep-linked breathing disorder, we need to start the patient on NIV. And after that, if the patient is still not satisfying any criteria, we need to repeat the patient's PFT every 6 months. We need to also assess the patient's symptoms every 6 months. And somewhere down the line, yes, the patient is going to require NIV. However, very important is to look out for the patient's cognitive function as well as involvement of any bulbar issues. So, if the patient has bulbar symptoms, or if the patient has cognitive dysfunction, the patient has poor cough reflex, and the patient is not able to clear out his secretions, eventually the patient will fail NIV, and in fact should not be started on NIV. The patient requires mechanical ventilation and tracheostomy. So when these patients are prescribed, so when what we do is we prescribe certain machines to these patients. So when we do this, we need to counsel the patient that they should buy a machine which can be used in the NIV mode. And also we should be able to connect the machine to the tracheostomy, because otherwise the patient has to purchase two machines and the cost is going to go up.
I think very well said, Dr. Nupur. I think many of our colleagues would be able to give more good answers to neurologists now regarding the use of NIV and PAP therapy to their patients. Dr. Mansi, as in the previous discussion, Nupur mentioned about the Guillain-Barré syndrome as a possible cause of unexplained respiratory failure. I know there are various variants related to it. So how to diagnose it? Management is a very critical part. And when, as a respiratory specialist, when you are called for, when you decide to intubate or take patient on mechanical ventilation? Dr. Mansi.
Sorry. So GBS is a common thing that we see in if you're working in a very busy ICU setup, and you have seen cases of GBS in your life. And as we all know that almost 25 to 30% patients of GBS would land up in respiratory failure somehow. So regarding the variants, when you have to suspect GBS, patients will usually present the respiratory failure is just one component of it, but mostly the patients will come with acute onset ascending type of facet paralysis. That is what the commonest presentation that you see in your ICUs, and that is it starts with the onset of there is a typical prior history of some sort of a upper respiratory tract infection, viral infection, or maybe a gastroenteritis episode, or maybe patient has undergone a surgery. So there could be a lot of triggers to it. And with that history, when you get a history of development of distal paresthesias, then acute onset flaccid ascending paralysis, then GBS obviously comes to your mind. There are a lot of mimics of GBS, but there are ways to distinguish them. But by far, with clinical history and patients, if your patient allows you, then probably nerve conduction studies are done, and you have some blood workup also, so you can find out. And regarding the two variants, classically there is a typical GBS, and then there are many clinical variants of GBS. But if we talk electrophysiologically, there are two major variants that we should be aware of as clinicians. One is AIDP, that is the acute inflammatory demyelinating polyradicular arthropathy. So that one is a more common variant in Indian setup also, and by and large. And regarding the other variant, that is the Aman or Amsan variety, where you have motor and that AIDP is a demyelinating. The primary physiology is demyelination, and the other one is your axonal involvement. So that is the Aman and Amsan, and that the prognosis with that variant is little, in terms of clinical recovery, maybe not that good as compared to AIDP. And when these patients are in respiratory failure, so how should you manage supportive care? And obviously, IVIG works well, and those kind of things. But when the time is needed for recovery, that time you have to support the patient's respiratory muscle involvement, and that is through either you need an invasive mechanical ventilation or non-invasive. So, respiratory failure, what could be predictors of how fast it could progress? So those patients who are actually having a rapid clinical course in terms of the aggressiveness of the disease will definitely have a much faster rapid respiratory course also. If the patients have bulbar involvement, if they have upper muscle involvement, upper limb muscles involvement, and they have cervicopharyngeal variant, so those are the pointers where, and if they have autonomic features of GBS, then these patients are more likely to develop respiratory complications also. Regarding when should you give them ventilation, I think Nupur has already stressed upon some of the points there. So classically, a patient who's hypoventilating, it starts in sleep. So you can see there is sustained hypoxemia during sleep when you're managing. If you're talking of unexplained respiratory failure, it will start in sleep, probably in the patient, start desaturating when they are sleeping. Then, if it is a frank failure, then patients obviously will have dyspnea, which is in terms of orthopnea during supine position, their FVC is lower. So, if your FVC, if you're able to do a PFT there are lung function things available. So, if your patient is able to perform any maneuver when you're or you can actually, if the patient is too sick, the single breath count in a patient, how many breaths he's taking, those kind of pointers can be used. And how bad, if your bulbar involvement is there, so definitely the respiratory muscle weakness is going to the intensity with which the patient is coughing. So if your cough reflex is too poor, the flows are not that good, they are less than 270 liters. So those kind of things are mentioned in literature. But by and large, if your patients are as per the, if as a clinician you're managing, if any patient of neuromuscular weakness is showing nocturnal hypoxemia, sustained hypoxemia with increased PCO2 above 45, that becomes an indication to start the patient on ventilation. The choice between invasive and non-invasive is totally dependent on how well he is able to preserve his airway and whether you'll be able to use NIV at all. So if you have bulbar weakness, your patient will not be able to hold a mask there. So probably airway secretions and other things will come into picture. So it's better to intubate the patient.
Yes.
So those things have to be looked into.
Very well said, Dr. Mansi. I think this is the call which has to be taken by the concerned clinician when to intubate or keep on NIV, because yes, the retained secretion, there are more tendency there is for the collapse of the lung. So obviously these all things has to be taken into entity. Now moving forward, Dr. Atri, we discussed your case with myasthenia and myasthenia crisis. There is one more entity which exists, that is Lambert-Eaton syndrome. I don't know how frequent it is, but yes, it exists. And maybe this is out of course question, but still need to be differentiated with myasthenia. So how we can go ahead with that?
One thing I would want to mention very clear, classifying someone as Lambert-Eaton is like a death sentence for that person, because the most common disease which causes Lambert-Eaton is a paraneoplastic syndrome from metastatic small cell lung cancer. Very few people walk away from a small cell lung cancer to tell the survivor's tale. So if we get a Lambert-Eaton, it is just like a death sentence for that patient. Literature reports that Lambert-Eaton is 20 to 25 times less common compared to myasthenia. The most important clinical tip for understanding, because see what happens now, these tests are very expensive to do. These tests take a lot of time. So if clinically you can differentiate, one very important thing is, in myasthenia, the weakness worsens with muscle use. the more you try to use the muscle, the more the weakness will worsen. In Lambert-Eaton, the weakness gets better with exercise. Person is feeling weak, person tries to exercise, the weakness goes away. So that is one very important clinical striking for Lambert-Eaton. The biggest cause for this is metastatic small cell carcinoma, which gives rise to basically some kind of defective or faulty antibodies, because these autoantibodies are often not detected by conventional tests. Sometimes ANA may be positive, and sometimes it may be rare or unclassified autoimmune disorder where this can occur. Although this is rare, but since it has a very bad prognostic value, so whenever you're getting this kind of peripheral weakness, try to rule out this Lambert-Eaton. Continue.
Very nicely explained, Dr. Atri, in simple words. Need to be differentiated. Now, another common entity that in many parts of our country that we've commonly encountered is possibly organophosphorus poisoning. Dr. Nupur, I suppose that you have also encountered few of those cases with organophosphorus poisoning, and ultimately challenges respiratory failure. So basically, how to manage those sort of patients?
So organophosphorus poisoning is quite common in India actually. And so in the developing countries, much more common than the developed countries, because organophosphates are more commonly available, and we don't really have much of, we don't have stringent laws. There's not much of regulation around the use of organophosphates. And very commonly, what we find is that the farmers are the ones, the patients who are coming in with OP poisoning. Of course, accidental ingestion and even suicidal cases have been noted. So the problem with organophosphate poisoning is that when the patient is brought in, patient is usually comatose or very drowsy. So it's very difficult to get a history from the patient himself. But of course, if there is an accompanying person, we may ask the family members history of the patient. At the same time, the other challenge is protection of the healthcare workers who are coming in contact with the patient who has come with OP poisoning. So, very important is that when a patient of OP poisoning comes to you, and when you suspect OP poisoning, decontamination is important. So we don't know what is going to be the route of entry of the organophosphate. It may be ingestion, it may be inhalation, it may be through skin contact. So what the first thing we need to do is wash the hands, the legs with soap and water. We need to remove the soiled clothes. Possibly, if the patient has long hair, cut the hair as well. And before doing that, the healthcare workers should ensure that they are protected themselves, because there may be accidental poisoning to them also. Very important is that OP poisoning causes a lot of bronchoria. So there's going to be increased secretions. So airway protection is also very important in these patients. At the same time, the patient may be drowsy, so may be hypoventilating. So airway protection again is important. So eventually these patients do require intubation. At the same time, patient may be dehydrated also. So patients usually have a lot of like increased secretion of body fluids. So they'll be having a lot of vomiting, gastric cramps. They'll be having a lot of sweating as well. So patients usually are dehydrated. So ensuring that their hydration status is maintained is also important. At the same time, patients may have seizures. So they may require anti-epileptic drugs as well. So the drug of choice usually in OP poisoning is atropine. So you start with somewhere around 3 to 5 mg, and the dose needs to be repeated every 3 to 5 minutes till your patient is atropinized. And once you have given atropine to the patient, after that it can be followed by 2 p.m. that is pralidoxime. Again, pralidoxime, not much of data is there as regards the mortality or the side effects, but still it is recommended that you give pralidoxime. Another important thing is when you are intubating patients with OP poisoning, we should avoid using succinylcholine, because that's not going to get metabolized in patients of OP poisoning. And it's going to cause prolonged paralysis in patients, and you're going to wonder what went wrong in spite of you managing the patient.
Recently, it has also been seen that if you give ECMO support, maybe VA ECMO, if cardiac involvement is there, that is also helping in some sort of patients in that way. Nicely explained, ma'am. So Dr. Nilanjan,
Yeah.
uh, we have a patient, we take on ventilator, we give sedation, we give relaxants. Eventually, patient, we come to know that patient is difficult to wean. Wean, we try some other modalities, we discuss, and eventually we come to some terminologies like critical illness neuropathy. I know these are nightmares for an intensivist, uh, but how to diagnose those if they are there, and how to manage it?
So coming to your question, I just wanted to add one small point for Dr. Question. There is one entity called intermediate syndrome, which occurs after 72 hours of
Yes.
poisoning. So that's also an important cause of respiratory failure. Right? We can call it unexplained respiratory failure in someone who has apparently become normal and free from poison. So this is because of in severe poisoning, the OP compound still gets deposited in our lipid tissues, and then it again is slowly released back to cause the toxic effects of OP poisoning. Just wanted to tell that point. And
Yes, yes.
yeah. And coming to your question, Dr. Ankit, yeah, critical illness neuropathy is definitely a nightmare for us intensivists because it increases the duration of ICU stay, increases the duration of ventilation. The patient can again go into secondary infections and ventilatory associated pneumonias and all. So the risk factors, as you have said, first of all, is the severity of the illness itself. If you are having an illness which is having a very high Apache score, the patient was very sick in multi-organ failure when he came. That is itself is a risk factor for developing critical illness. Uh, the next one is if your patient has been receiving neuromuscular blockade for long duration, like your patient, suppose you have a patient of ARDS and you are being sedating and paralyzing this patient on ventilator for say 4 to 5 days continuously. This itself is going to create neuromuscular weakness. Another risk factor is high dose steroids. As we mentioned earlier, steroids is a rescue therapy, but if you prolong give a prolonged course of steroid or a prolonged course of high dose steroids in certain conditions can cause critical illness neuropathy. So, if coming to how to diagnose the classical presentation clinically would be the patient will have severe weakness of quadriparesis, severe weakness of all the four limbs. He will not be able to move his, the power of the upper and the lower limbs will be low. The patient might have been extubated, but again will require reintubation because of respiratory failure, ultimately requiring tracheostomy. However, the consciousness, the sensorium of the patient will be quite clear. The patient will not have any cranial nerve involved. And the definitive diagnosis is by a nerve conduction study. We do a nerve conduction study. We get a characteristic pattern for this critical illness neuropathy. So, treating critical illness neuropathy is really difficult. There is no as such treatment. It is mainly supportive. It takes a long duration of time. We have to gradually wean the patient off from the ventilator, probably give a much prolonged duration of pressure support trial, and we will require tracheostomy. The main aim is supportive treatment, preventing further infections. And if we are able to extubate a patient, he will require again NIV for a long duration. So, as such, there is no one antidote or any specific treatment for critical illness neuropathy.
Rightly said, Dr. Nilanjan. I know this is the not so frequent, but yes, it is an encountered entity, and really it is a nightmare for those who are treating it, because what to explain and what to discuss with the relatives. I would like to thank our cardiologist friend who has been patiently listening all the discussion all through the respiratory failure. But dear friend, nothing is complete with the cardiac without cardiac. And Dr. Arpit Jain, we know that a very and frequently encountered condition is orthopnea. Uh, I know we need to evaluate there could be certain cardiac reasons for certain unexplained respiratory failure. Would you like to throw some light on it?
Yeah. Good evening, sir, and I'm really privileged that you people invited me here. And cardiac and respiratory causes goes hand by hand. See, anything which causes the hypoxia, inflammation, cytokine release will ultimately lead to the systolic and diastolic dysfunction. In the same way, the systolic diastolic dysfunction in the heart anyway will going to increase the preload, and ultimately the pulmonary congestion will take place. So almost we are dealing with the same disease frequently. And orthopnea per se is most common cause is cardiac only. Besides ascites and some reports of the COPD patient having orthopnea, but always if the patient coming to us with the orthopnea complaint, the cardiac cause has to be ruled out. Systolic dysfunction can be easily ruled out by the ECG and the patient having any prior history of chest pain or MI. What we are missing nowadays is diastolic dysfunction or heart failure with preserved ejection fraction. So now we have divided the heart failure into the three entities. If it is if the EF ejection fraction of the heart is more than 50 and still the persistent symptom of the shortness of breath, we term it as heart failure with preserved ejection fraction. So diastolic dysfunction is one of the things which we have to look in each patient. There is a study few years back which said 20 to 68% of the respiratory failure patient was having diastolic dysfunction. And diastolic dysfunction per se was the independent marker of mortality in those patients.
So you get to have more hypoxic respiratory failure or hypercapnic respiratory failure in your routine clinical practice with patient with cardiac failure. Any specific or a combination of both, hypoxia followed by hypercapnia, or what? Any entity?
See, mostly hypoxic only, but anytime if the respiratory patient is involved, like COPD patient, or there is a patient with fibrosis, post-COVID fibrosis, anyhow the CO2 level will be raised. Then we have to see the ABG, and depend on the bicarb, we have to see the persistent level of the
eventually, what is the management protocol for you for these set of patients?
See, for as a cardiologist, if our concern a patient came for the respiratory failure, the diuretic is one of the cause. If mortality, anyhow, we have to decrease the LVEDP. So compliance factor is a different thing, but LVEDP, the left ventricle end diastolic pressure, has to be reduced. And the first thing which can be reduced by the diuretics only, and which gradually lead to decrease in the pulmonary congestion. And
our cardiologist friends are very fond of BiPAP supports and CPAP support given to those patients. Does it help in your practice also, or as a cardiologist perspective? I am not talking about the science behind it, but they are very that someone in failure, okay, put something on the PAP therapy, maybe a CPAP could help, maybe a BiPAP could help. You also prefer those?
No, we prefer those, but that positive end pressure expiration is required. For hypoxia, that we prefer, but anyhow we have to decrease the pulmonary congestion. The pathophysiology is to decrease the LVEDP anyhow, and these all factors are depend on the compliance of the lung and the compliance of the heart. If the preload is increased, any preload and afterload, these are the two factors which work together. No, so if we have to decrease the preload or afterload, nitrates, diuretic, and yes, NIV and CPAP support is required.
Any arrhythmias complicating the stuffs?
These are the sequence of the event. That's why the first case, Dr. Atri sir, Holter. Why Holter was put? Because AF causes this orthopnea. Systolic dysfunction, diastolic dysfunction, AF, hypertensive cardiomyopathy. There was a case I was seeing last few days ago. There was a MR which was only precipitating when the BP was increasing, and it was causing the failure, and patient was getting intubated again and again, has to admitted. And once the dialysis was done, everything was settled. CKD patient MR was resolved, and the dyspnea was reduced, and the pulmonary edema reduced. Other factors we have to look in the issue is restrictive cardiomyopathy or constrictive pericarditis. In the tuberculosis patient, as a respiratory point of view, the amyloidosis, which is still under diagnosed in cardiac patient, or even the patient with the persistent heart failure, or sarcoidosis. These all both the
Sometimes,
conditions.
yes. Sometimes we get a very bad combo, or like COPD with CHF with CKD. Your things are haywire, things are not moving around. So these are the difficult entities that definitely we encountered. But yes, management of CHF is very important in these set of patients, what the traditional thought have been. Thank you, Dr. Arpit. Dr. Atri, we are now thinking of things outside respiratory systems, abdomen, a very frequent cause for respiratory failure. I would like you to slightly throw some light on obese patient also, particularly talking about obesity hypoventilation syndrome.
I will not enumerate a very big list for people to mug up and get bored. One thing I would want to stress to the beginners is cough breathlessness is lungs. Breathlessness without cough is not the lungs. So someone is having breathlessness, no cough, think beyond the lungs. When you are talking about abdomen, Nilanjan ji very beautifully told about diaphragm. I will not repeat that. Obesity leading to respiratory failure, obesity, hypoventilation cases will increase. All of us, whether in respi practice or general practice, we are seeing that a lot of increase in obesity. There is absence of land for children to play muscular activity. Even when we are adults, we have these wonderful mobile phones which can catch us on in a sofa for 2 to 3 hours like anything. Then there is so much advertisement regarding home delivery of delicious food items. So obesity is going to be one big story, whether it be pulmo, whether it be cardiology, dermatology, infertility practice, osteo, orthopedics, anyone.
Eventually.
So obesity leading to respiratory failure as the BMI increases. Beyond 35, start suspecting. Beyond 40, start confirming. Do one ABG, a person BMI greater than 40 and ABG where there is either decreased PO2 or increased PCO2, stamp that person as obesity related respiratory failure. Increased PCO2 is obesity hypoventilation syndrome. BiPAP or PAP therapy is a stopgap measure. The treatment for this person is to lose the weight. How lose the weight? Whether it is medicine, whether it is diet, whether exercise or surgery, depending on severity. If I move away from obesity, I want to talk on some more common things in the abdomen that cause respiratory failure. Chronic kidney disease or uremia. Often chronic kidney disease can be silent and the first diagnosis is from a blood test that someone went for a routine health checkup and found that urea creatinine in horrible range and you came to know this is CKD3, CKD4. So chronic kidney disease due to this silent water retention can cause respiratory failure. So middle-aged person, prior history of renal calculi, coming to respiratory failure, think about chronic kidney disease. Sequelae of pancreatitis. Acute pancreatitis is a very violent and volatile condition, but due to thanks to this wonderful critical care people, Pan India, Mansi ji is one, Nilanjan ji, even our moderator Ankit ji, you all are wonderful critical care people. You save acute pancreatitis patient. But after this, they are unable to do the follow-up properly with a good gastro person and they develop certain sequelae of pancreatitis. One very thing is a space-forming lesion known as pseudocyst pancreas. These things, by their compression, they can also land up into respiratory failure. Liver and portal vein related obscure pathologies. There may be parasite invasion in that portal vein tree. There may be some thromboembolic phenomena in that portal venous system and certain autoimmune liver diseases or liver-related pathologies can also lead to respiratory failure. These are common things which we encounter and we should suspect not to miss out these things because all these things can be treatable if caught early. CKD stage 3 can be reversed nowadays. Liver disease, portal vein disease has wonderful treatment if it has not gone into a bad state. So think of these things from the abdomen. Please continue.
Yes, very nicely elaborated, Dr. Atri. yes, these causes needs to look for. Dr. Mansi, in our clinical practice, possibly we have encountered many structural lung diseases. So what is the point in which we decide, beside the conventional treatment, that your patient may require a PEP therapy? Dr. Mansi?
Hello?
Dr. Mansi,
Yes.
I need to repeat the question.
You were saying about need for
Structural lung
PAP therapy.
diseases.
Yes.
Yes.
So if we're talking of the thoracic cage abnormalities, the structural lung disease can be involving any part of the lung. One, we're talking of the thoracic cage and the pleura, which is primarily a restrictive lung condition in terms of the lung and the chest wall compliance. So it depends on whether the patient is amenable to any surgical correction, because these are things which a surgeon might need to be involved if it's an early
Yes.
stage involvement. But if the patient has gone beyond that stage and there are no surgical options, then obviously treatment actually remains supportive. So in supportive treatment, where we need to focus on, because these patients have inspiratory muscle problem, inspiratory effort problem due to their compliance issue. So they're not able to generate good breaths. That's the reason probably we need a ventilatory assistance, which is in the form of a PAP therapy. Where you need a pressure support to help them augment their effort. The other problem they have is that they're not able to clear out their secretions well. Their expiratory muscles are also not very well working because of the loss of chest wall compliance. So in that scenario, they need to be supported with airway clearance therapies, with which they can generate a good cough effort. And the ventilatory settings also sometimes might need to be augmented to enhance their cough effort, which could be in the form of a breath stacking maneuver or something like that. Some patients are not able to generate a good, because there's a lot of breath to breath variability during non-invasive ventilation. So sometimes volume targeted modes are also needed for them. So again, it totally depends on what stage we are. And important thing is that maybe these patients are not having initial daytime hypercapnia. So a lot of times we miss on diagnosing this respiratory failure in these patients, because it's all happening in the sleep time. So sleep apnea and hypoventilation, sleep-linked hypoventilation is primarily the first thing that whenever a patient is referred to you with any kind of neuromuscular or thoracic abnormality like a kyphoscoliosis, you should always try and do their sleep study and find out whether they have any kind of sleep-linked dip in their saturation or buildup of CO2. That is the time, if it is happening, it's better to timely start with an IV therapy there.
Very well said, Dr. Mansi. Dr. Arpit, in our practice, we commonly encountered pulmonary hypertension, particularly in those group of patients, particularly pertaining to lungs, maybe COPD, interstitial lung disease. Does these pulmonary hypertension cause any kind of unexplained respiratory failure?
Sir, anyhow, the Heath-Edward classification for pH, it from medial hypertrophy to plexiform lesion to necrotizing arthritis. In the end stage, these all will progress, and anyhow, it will further lead to endothelial 1 receptor activation more, decrease NO, decrease your sildenafil or any tadalafil. They will not going to act because the NO will reduce more. It will cause further remodeling. It will cause further inflammation, and particularly as the disease progress, it will affect the heart, both side of the heart, and patient will succumb anyhow. LA compliance will decrease, arrhythmia will precipitate. Yes, it will cause, but the theory is the lesion only. From that Heath Edward all itself only ki last 3 plexiform lesion and necrotizing arthritis are irreversible. So anyhow, if it progress like that, it will cause pulmonary edema.
I know the treatment options are there for certain group of patients with pulmonary hypertension, but I think it will need just another webinar for the treatment management options of pulmonary hypertension. So I'll not go into that details. Dr. Atri, we have pulmonary function test. Do you find its role in the diagnosis of these kind of patients, unexplained respiratory failure?
I am very happy when you asked me about pulmonary function test.
I know.
Last 2 years, wherever I go across India, I'm very happy to see that PFT has been rediscovered and lot of workshop, lot of session are being given to PFT. In an acute presentation, obviously we cannot do pulmonary function test. But when we have this chronic patient, spirometry will not help us too much. We need to think beyond spirometry. There are some tests which were earlier called as advanced PFT, which are probably now increasingly popular pan India. One is a DLCO, diffusion lung capacity. Wherever you are thinking like these autoimmune pathology sometimes have some interstitial lung disease pattern, and you can find this impairment in the DLCO, muscle related weakness. There will be impairment in the lung volumes also. Another new test has come up, oscillometry. Oscillometry, although it is still we are learning about it and the science is still yet to be standardized, but there are sufficient published literature now. Oscillometry is something wonderful in children. In children, if you are dealing with something where you are not sure what it is, oscillometry can give you a good help. In adults, oscillometry is something wonderful, especially in rheumatology related lung disease, where the first thing to be involved are the smaller airway bronchiole. And if you are getting a normal X-ray, if you are getting a normal spirometry, but in oscillometry, if you are getting something worsened small airway disease, kindly think that you are missing something and you need to explore more in the patient. Another place where this PFT will help is once you made a diagnosis using some whole body imaging, some ultra expensive blood test, and you started this patient on rituximab, other autoimmune therapy. Now you want to know how is the patient behaving, whether the patient is improving or whether the patient is deteriorating. This oscillometry and DLCO are very small, readily available, non-invasive, non-radiation, relatively cheaper test that will help in follow-up of these kind of patient.
Yes. So you defined a very good role of PFT in our clinical practice. Yes, we can do it. Dr. Nupur, any respiratory condition causing unexplained respiratory failure from your point of view?
So respiratory, we have multiple conditions. For example, patients with overlap syndrome. So someone with COPD coming with respiratory failure is quite common in our practice. But we must remember that these kind of patients usually, before they develop diurnal respiratory failure, they start developing respiratory failure in sleep. So usually, overlap syndrome, COPD patients, bronchial asthmatics who are uncontrolled, they may come with respiratory failure themselves. Patients with bronchiolitis also. Someone with pneumonia, it's obvious they usually come with respiratory failure. Vascular diseases. So someone like we discussed earlier, and Dr. Arpit also mentioned. So someone with pulmonary hypertension. Patients of pulmonary hypertension may present with respiratory failure also, and that's probably something we may miss because usually what we have available with us is an X-ray or a CT, and usually the lung parenchyma are normal in that. Large effusions. So large pleural effusions or a massive pneumothorax may also push the patient towards respiratory failure. Patients who have interstitial lung disease. So many patients with ILD also may come with respiratory failure. It may be just IPF or maybe CTD related ILDs as well. They may also come with respiratory failure.
Yes. Dr. Nilanjan, sometimes we have patient with chronic liver disease, patient with hepatopulmonary syndrome. But when we see radiological findings in terms of CT chest is normal, X-ray is normal, but we have a respiratory failure in them. How to confirm the diagnosis? How to treat it?
Yes, hepatopulmonary syndrome is a common cause of respiratory failure in big liver disease. And it also indicates the severity of the liver disease, common in advanced liver disease. So what happens is, as you have mentioned, that we'll get a clear X-ray and a clear CT. It's because of the vessels, the pulmonary vessels which are dilated, and this is what is causing respiratory failure. So for diagnosis, the ABG is the first thing that we see increased alveolar arterial gradient in our ABG, while there is no other findings in on clinically or auscultation or radiologically in our respiratory system. And for confirmation, we can do something called bubble contrast technique. So that is done when we inject agitated saline. We can inject agitated saline through one of our peripheral veins. And after 4 to 5 cardiac cycles, if we do an atrial vein, after 4 to 5 cardiac cycles, we see that the left atrium, the opacification or this bubbles will be there. So once we get this, that is confirmation of an extrapulmonary condition, and this confirms our diagnosis of hepatopulmonary in a liver in the settings of a chronic liver disease. And treatment-wise, again, unfortunately, liver transplantation is the only definitive treatment. There is no as such other treatment, only symptomatic management. Often these patients end up with long-term oxygen therapy and some might even require bypass. So treat the liver disease as much as possible and symptomatically, or go for a liver transplant.
So it's very important to be aware what is happening outside lungs also, because eventually they can involve and cause respiratory failure. Dr. Mansi, the very frequent entity that we as a pulmonologist encounter is ARDS. I know there are the revised criteria, they are there for the diagnosis and eventually management of ARDS. We are not going into details of ARDS because it itself will take one entire webinar to discuss. Just for our respiratory physician friends, how to diagnose it early? That maybe our patient is going into ARDS?
Yeah, actually, it's an extensive discussion on ARDS, but picking up the entity early means that when you're suspecting it. So, as a clinician, that we know that the definition has a lot of pointers to it. ARDS is a very rapidly progressive condition over a week or 10 days. So, you have to actually go into the background of the case. If your patient is admitted with you, suppose, and there are predisposing extrapulmonary conditions like a patient had a recent surgery, or he's in the burns ward, or he's having a pancreatitis, but he's still not in respiratory failure. So you should be on the guard that these are the likely conditions where the patient is going to have he's predisposed to develop endothelial dysfunction as part of the inflammation going on. And ARDS is one of the complications. So one is that. Then the other thing is repeatedly examining the patients for change of vital signs. So one thing is just not measuring the SpO2 as such. So we must understand that a patient who's going to have developed hypoxia, he's going to compensate the hypoxia primarily by increase in cardiac output, which is basically tachycardia, and it's also going to increase the respiratory rate. So if your patient is having tachypnea, he's having alkalosis, his patient is having palpitations, lightheadedness, then those are the features that you understand that he's having an impending respiratory failure. Maybe his saturation is still well maintained. So you don't go just by the saturation. If you're getting too much of alkalosis and your PO2 is in the normal range, but your A gradient is widened and your patient is already having hypoxia. So don't take this patient lightly. He's probably landing up. They're doing a chest X-ray on auscultating. You're finding some crackles there and some new fuzzy infiltrates. I think your patient is already into evolving ARDS. You better start managing on those lines.
So possibly we need to be vigilant, and we should have all the things ready with us. Possibly our patient is going into impending ARDS. Dr. Nupur, hormones are an important entity, and there are certain endocrinological diseases which cause unexplained respiratory failure. Could you just throw some light on it? What are those endocrinological diseases?
So when it comes to endocrinological diseases, I think most commonly that we see is thyroid. So either hypothyroidism or hyperthyroidism, both patients can end up with respiratory failure. So someone with hypothyroidism, they usually have respiratory muscle weakness. They may have increased weight. They will have macroglossia. That's going to predispose them to developing sleep apnea. That itself can cause respiratory failure. And someone with severely depressed function, so someone with mixed edema coma, they usually have hypoventilation and they do come with hypercapnic respiratory failure. At the same time, someone with a thyroid crisis can also land up with respiratory failure. Then you have other issues like someone with the diabetic ketoacidosis because of the metabolic acidosis may land up with respiratory failure, may be dehydrated also. At the same time, you have the adrenals. Adrenals also are important. So someone with Cushing syndrome or someone with Addison's disease can also develop respiratory failure. Another important disease which I forgot to mention is Graves' disease. So someone with Graves' disease can have a lot of autonomic dysfunction. So these patients usually can have a lot of ventilatory instability, which can also push them towards respiratory failure. Someone with hypoparathyroidism, because of the hypocalcemia, they can also have respiratory muscle weakness. They can also end up with respiratory failure. And another system that we need to see basically is something below the diaphragm, like Dr. Atri said. So someone with a female with ovarian tumor may present with a large effusion. So Meek syndrome also patients can present with respiratory failure. Another important reason is any patient with a testicular mass, so testicular CA with florid lung mets can also present with respiratory failure.
Yes, definitely. Dr. Nilanjan, any ER management will change in these type of patients, or just we have to stick to the basics?
Yeah, for emergency management of explained, if you are asking unexplained respiratory failure, I assume that we have ruled out the common causes, the common respiratory and cardiac causes. So for this, the next system that we need to target is the central nervous system. So as in every ER department, the basic thing is ABCD. We need to stabilize the airways, see the breathing,
Yes.
and the neurological assessment. So the simple dictum is if the patient is coming with drowsiness, his airway is threatened, and he is in respiratory failure, we'll have to intubate him. Intubation and mechanical ventilation. If the patient is conscious awake, we can probably give a trial of NIV,
Yes.
non-invasive ventilation. And then we have to rule out all the causes that we have mentioned.
Yes, definitely. I think we have to stick to the basics in the ER. I know the definitive management and diagnosis will follow up
ABCD.
in the subsequent time. So I think we have given answers to most of the questions which were there with the audience. There was one by Dr. Naeem from Jammu and Kashmir to Dr. Nupur, that why she used anticoagulant in this patient with diffuse alveolar hemorrhage. Dr. Nupur, you want to answer this? You are on mute. Dr. Nupur, yes.
This patient, so basically patients with antiphospholipid syndrome, when they have pulmonary involvement, what we need to see is what is causing the pulmonary involvement. So most of the patients usually have an underlying pulmonary embolism. That is the most common way in which the patients have a respiratory involvement. The second is diffuse alveolar hemorrhage. And the third is coexistence of both. Right. So when your patient is patient is already intubated in a critical care setup, usually they are started on prophylactic anticoagulation. So the patient wasn't initially diagnosed. So when we did the quantitative D-dimers, they were normal. The patient's echo also did not show any features of pulmonary embolism. So actually, the patient was not given high doses of anticoagulation. She was in fact given steroids, cyclophosphamide, and plasmapheresis. So if your involvement is going to be because of pulmonary embolism, or if there is no pulmonary embolism, but there's going to be multiple microthrombi, these are the patients who usually require anticoagulation.
Okay. So it was a very wonderful discussing with you all about the unexplained respiratory failure. So the concluding remarks. Dr. Atri, your point, your take.
In the acute case, try to save the life first. But once the patient is stabilized, don't settle for empirical solutions. Seek evidence. If someone had a respiratory failure, don't rest until you get a diagnosis. Please discard empirical approach.
Dr. Nupur?
So, like I agree with what Dr. Atri said. The we have to see the setting in which the patient comes to us. Most of the times it's an acute setting. So most importantly, we need to stabilize the patient, secure the airway of the patient. Once the patient is stabilized, we also need to look at the overall picture. So whether it's a male, female, how rapidly the disease has progressed, whether there's multi-organ involvement, also whether the patient, the patient has had any significant past history. That's going to help us guide our investigation. So we need not do a blanket investigation for all. We can do guided evaluation for such patients, and we also have to be vigilant. So sometimes what the disease or the patient appears to be may not be the actual case. We need to look out for markers in which the patient may have either an alternative diagnosis or may have two or three multiple diagnoses in one go.
Nicely said. Dr. Nilanjan?
I would say stabilized and then investigate the patient. Mostly the the history and the clinical examination will give some clue to the diagnosis. And please involve your colleagues from other departments as well. They will certainly help in getting a diagnosis better.
Dr. Mansi?
So everyone has said something nice, but I just want to say that a lot of unexplained respiratory failure, I've emphasized enough in my discussion also that it starts in sleep. So don't ignore sleep symptoms in such patients, because that part is mostly ignored in our busy setup, and that is in OPD. In a patient who's in intensive care and under you, then you have to go by the basic flowchart, follow an algorithm of workup of respiratory failure. I'm sure you're going to get the cause of your respiratory failure.
Yes. Dr. Arpit, any comments from your side regarding...
No, sir, everything has been said. Just keep a echo probe there and try to see the LV function and keep the eyes on the arrhythmias. That's all from my side of it.
Yes, the central part is very important. So thank you all. It was wonderful interacting with you, Dr. Atri, Dr. Nilanjan, Dr. Nupur, Dr. Mansi, and Dr. Arpit, for this wonderful out-of-box topic. And I would like to congratulate and thanks CCI, Chess Council of India, Dr. Krishna, Dr. Vijay, Dr. Shivani, with coming up with this out-of-box topic to discuss on this prestigious platform. I would like to thank Alkem for our partners. Thank you all for this wonderful academic discussion. Thank you.
Thank you. Good night to everyone.
Good night.
Thank you, everyone.